Okay, sorry if you all out there in the video audience were muted. Hi, Dr. Rao, I see you there. I think that there's quite a bit of sort of basic education in the treatment of patients with benign and malignant skeletal sarcoma, skeletal tumors, and also soft tissue tumors. And so I thought we'd just really start with a lecture that talks a little bit about the basics of taking care of somebody who has a skeletal sarcoma. Now, of course, when they come to you, you don't know that they have a skeletal sarcoma. So following a very systematic plan as to how you're going to approach that is incredibly important. So what we will talk about today is staging, biopsy, resection, reconstruction. And then we'll talk a little bit about some of the specific tumors, specific skeletal sarcomas that we encounter. So why do we stage people? I mean, what's the reason to do that before? Why do we do that whole workup before we do the biopsy? Why not just go in and do the biopsy? Well, it allows us to sort of predict prognosis, how patients are going to do. It allows us to compare patients and allows us to tailor their treatments. And what does that mean when we say we're going to stage the patient? People are, everybody's sort of, for whatever reason, people kind of come in with an MRI first. And I will tell you that for skeletal sarcomas, MRIs are important. For metastatic disease, MRIs are not so helpful. You'd rather have a CAT scan so you can plan your surgery. But when we do talk about stagings, the basics is getting an X-ray of the entire bone. It allows for you to look at the matrix. You can look to see what the effects on the bone is, and really to localize the lesion. What are the things that we're kind of looking for on X-rays? Well, these are some of the radiographic signs of malignancy, right? Can anybody tell me what this is called? This is my mouse. Sorry, the picture on your left. Onion skinning, right? And then how about this, where the arrow is? Right, Codman's triangle. And then how about the picture all the way on the sunburst, right? So these are radiographic signs of malignancy. So if you're seeing these, they can also be infection, particularly this onion skinning pattern. But if you're seeing some of these signs, you say, this is, and I say on the phone, does it look radiographically malignant? The answer is yes when you're seeing these things. You also want to make sure that you've scanned the chest if you're suspicious for a skeletal sarcoma. Typically, if you're dealing with somebody who's older, you're going to be maybe thinking about Mets, myeloma, lymphoma. And so then you want to get a chest, abdomen, pelvis so that you can look at the entire, all the body cavities. But if you're thinking skeletal sarcoma, the minimum is that you get a CT of the chest, because the #1 location for skeletal metastasis is to the lungs. What's the second most common location? We're going to get to that. That would be the reason we get a bone scan. So it's the bone, right? So most common location for skeletal sarcoma Mets is to the chest. Second most common location is to another bone. So you want to, if you can, get the bone scan before you do the surgery. You can't always do that because it does take kind of a day and you have to be in the hospital. But if you're treating somebody who has metastasis, they may have pain in another bone, and you could have prophylaxed that when you took them to surgery. If you're dealing with somebody who has a skeletal sarcoma and they have a lesion in another bone, you could have biopsied that when you biopsy the first lesion. So if you can get the whole body bone scan before you take the patient to the OR, that's advantageous. That being said, that doesn't always work out. We also want to get an MRI of the entire bone, right? So if the second most common location is another bone, you have to be concerned also that the patient's going to have skip metastasis, right? So a lesion within the same bone. The MRI allows you to really surgically plan to look for any extraosseous extension, to look for skip metastasis, and it also really allows you to see where the soft tissue mass begins and ends. And you can see in this example that the MRI is incredibly accurate for telling you where you're going to be able to start and stop your resection. So in this patient, we were able to actually save the articular surface and do an intercalary allograft. But you would only really know that if you had a good quality MRI, and the quality of the MRI is going to be better if you get it before the biopsy, before you have all this edema from your surgery. You also need to get some labs. And we say that very loosely. Well, what labs are we going to get, and why are we going to get all these labs? Again, we don't know that the patient has a skeletal sarcoma. Usually if they're, young, we kind of can assume that. And so you maybe don't necessarily need to get all these labs, but in an adult patient, you're not necessarily thinking that's what it could be. And so you need to get some basic labs, SPEP, UPEP for patients who are older, BMP, CBC. So if a patient has myeloma, what might you see on the CBC? Anemia, right? So it can give you a little bit of a clue. So you can go to the pathologist and look really smart because you're like, oh, he's got anemia and multiple lytic lesions. I think we might be dealing with myeloma. What might you see that's abnormal on the BMP? Say it again. Right. So elevated BU and creatinine, right? Because patient might have Binns-Jones protein. So those are kind of things that help you just clue into what you might be looking for, because the SPEP takes longer to come back sometimes than the biopsy. I don't know, maybe it's not that case here. For males, you typically want to get a PSA to make sure that you're not dealing with prostate cancer. An ESR can be very helpful. It's generally can be elevated in things like lymphoma and also in Ewing's sarcoma. But it's also can be elevated in infection, so that doesn't help a lot. This is a case where, you know, we would have thought that this for sure was going to be a sarcoma, but it turned out to be osteomyelitis. So having your SED and your CRP is helpful in, again, going to the pathologist and saying, well, this is what we have. It helps them come up with a better differential before they even seeing it on the slides. And you also want to make sure you're checking your calcium levels. So you really feel stupid when you go to pathology with what you think is a terrible tumor, and then they ask you what the calcium level is, and it's 17. And then you find out the patient has brown tumor, right? That they've got parathyroid dysfunction. And that's the reason they have all these lytic lesions, right? So you have to be aware that not only are you a surgeon, like KG says, but also a physician, right? You need to remember all the calcium, phosphorus, hemostasis, and how that all plays into what your bones look like, because you might just be dealing with a metabolic bone disease problem. LDH isn't super helpful, but it can be elevated in lymphoma of bones. And then finally, once you've had all that done, you've got your CAT scan, you got your MRI, you have your labs done. You can sort of you can stage the patient before you also need to have your histology as well, but you can stage the patient based on where it is in the bone and whether or not the patient has METs. And then ultimately, once you get your biopsy done, whether it's low or high grade. So this is common in training question. I think that most people would be able to answer it, and this is the Anakin classification. So when you're talking to the cancer doctors, they typically are not using the Anakin classification. So when they say stage 4, they mean metastatic disease. When we say stage 3, we mean metastatic disease according to this staging system. What is the most common presentation for skeletal sarcomas? What stage? Say it again. 2B, right? So most of them are high grade and they're extracompartmental, but don't have METs. That's sometimes on the inter. So what does that look like? Well, inter or extracompartmental. So this is an example of what that looks like. This is one of the, this is an adamantinoma. So we know that adamantinomas occur in the tibia. They are one of our few low-grade sarcomas. So they're treated just with surgical resection. But that's what it looks like to be intracompartmental, right? Most sarcomas are extracompartmental. They reside outside of the bone. Looking at grade, you're looking to see whether, and I'm not a pathologist by any stretch of the imagination, but you're looking to see how much cellularity there is, how much necrosis there is, how much atypia there is, and they utilize that to grade things histologically as low or high grade. So this example of a low grade cartilage neoplasm, and this is a high grade osteosarcoma, right? So you see the lace-like osteoid and malignant cells that are interwoven into that. And then part of the staging system too is whether they have regional or systemic METs. So they both count as METs, right? So this patient has a skipped lesion right here in the troch. So that's why you got to get the whole bone. It's helpful if you get the whole bone on one view. Some people are really tall and they'll do the upper and the lower. It's enough to take them for a biopsy, but when you're planning surgical resections and you're trying to figure out lengths and how much bone is remaining, it's really helpful if you have everything on one MRI. And then this is a little pulmonary nodule. So that counts, as METs, even if it's really tiny and there's only one. Advances in staging, we were just talking about getting a whole body MRI, which I've never actually done before, but apparently Dr. Blika has, so it can be done. I'm sure that it would pick up quite a bit of disease. I was just talking to one of the residents about a kid that we biopsied here that had a distal femur osteosarcoma, and they got a PET scan, and the PET scan shows a little bit of uptake in the, this was a distal femur lesion. The PET scan shows some uptake in the tibia. So repeat MRI of that area showed that she probably has a lesion there as well. And MRI would probably pick up disease that we didn't even know exists. So it could probably be really scary to get that. I don't know if that'll ever catch on, but in lieu of that, we do use PET scanning. So PET scanning is a PET scan along with the CAT scan. So the fuzzy picture up there on the right is the PET portion, and the CAT scan is adjacent to that. And then they fuse the images to look at where the uptake corresponds to locations within the skeletal system and outside the skeletal system. So after you've done your staging studies, then you want to move on to doing a biopsy. And again, we talked about a little bit about why you do the staging studies first, but a couple other things come up, right? So other sites might be identified in your staging studies that are easier to biopsy, right? You don't want to biopsy the spine if you can biopsy the front of the tibia, right? And if you don't do your staging studies ahead of time, your limb salvage surgery can be compromised. You might also be able to avoid a biopsy if other studies are helpful. So in patients with myeloma, you can diagnose them by serologic criteria and having multiple lytic lesions. The pathology, the heme onc doctors still like to have pathology, but you can pretty much make the diagnosis without a biopsy. And the pathologists don't have to work blind if you do your staging studies ahead of time. You know, they will often ask you, do they have a lung met, or do they have a liver lesion? What else is going on? And then you can also identify lesions that are associated maybe with that diagnosis too. So if you're thinking, oh, this might be a sarcoma, but then you have multiple lesions and it turns out it starting to look like polyastotic fibrous dysplasia, that's just helpful before you get to the OR. Another reason is that the lesion may be vascular, right? So there's a patient with a renal cell carcinoma, and those are really vascular. So you can see what the angiogram looks like pre-embolization. You can literally lose, liters of blood with a biopsy of a renal cell carcinoma, and you can lose liters when you're operating on them as well. So also something you want to think about when you're doing your fixation. You may want to do something that's closed rather than open, but just having this information ahead of time before it's a bloodbath can be helpful. We know that when biopsies are done at the referring institution, that the chances of errors, complications, and changes in course are higher. Mencken did this study years ago, repeated the study, and it really hasn't changed. That being said, I do think that with CT-guided biopsies and with conversations with surgeons at referring institutions, that biopsies can safely be done by people that are not orthopedic oncologists. It just requires a little bit of coordination and some conversations about what that might look like. So this picture is an example of how you don't want to do the biopsy, right? This is a big incision. It's intra-articular. There's clearly a lot of surrounding edema, probably a lot of, probably large hemarthrosis that's spreading the extent of disease. So if you're trying to excise that biopsy tract out when you do your definitive treatment, that can be challenging. So what are our principles of biopsy? Well, we want to make sure that our biopsy tract is in line with the planned surgical resection. We want to use longitudinal incisions. And if we're going to have drains, we want to put them in line as well with the surgical incision. You want to basically go right through the compartment, right into the lesion. We're so used to doing intra-compartmental approaches. Tumor is the opposite. When you're thinking that it could be a sarcoma, you really want to make sure that you're going through the compartment and not contaminating all the adjacent neurovascular structures. Again, performed by the treating surgeon if possible, maintaining meticulous hemostasis. So this is an example of not meticulous hemostasis, right? You see all that bleeding. No contamination of separate sites. So if you're doing 2 biopsies, you want to use separate sets. You don't want to make skin flaps. You don't want to expose the vessels or the nerves. You want to make sure that you don't have transverse incisions, because when you go to re-excise that, now you've got to do a really large excision to get that out. You want to make sure that your sutures are very close to your incision. You would like a nice straight longitudinal incision rather than a curved incision with obvious, sutures that are far away from the incision. once you've figured out that what you're dealing with, you have to figure out what kind of surgical margin do you need for your tumor. So for things like giant cell tumor of bone, we use intralesional excisions. For things like lipomas, we use marginal excisions. For sarcomas, we use wide excisions. We use the term radical a little bit loosely because in our CPT coding books, radical resection refers to the removal of a sarcoma. But what we're really primarily doing is getting a wide margin, right? Because if you have a distal femur osteosarcoma, a radical resection is taking the entire bone. That's not what you're doing here. You're going through essentially a cuff of normal tissue. And people always say, how big does that cuff need to be? Well, we don't really know. Like, you just want it to be negative. And there are some tumors where we have very planned, close margins. If you're trying to say preserve the sciatic nerve, you might be sort of dissecting that off and leaving the epineurium with the tumor, and you're close. So that's a wide margin. You know, I think we define really as anything that's negative histologically. So once you've decided what your surgical margin is going to look like, you need to decide what your resection is going to look like. So you have basically two choices. You can do limb salvage or you can do an amputation. And if you're going to do limb salvage, you want to make sure that your function is comparable to an amputation, right? It doesn't make any sense to preserve a limb that isn't any better than an amputated limb. And you want to make sure that your risk of local recurrence is comparable to an amputation as well, right? You cannot sacrifice the oncologic outcome in an attempt to preserve the limb. So what does that really look like? Well, it used to be that anybody with a sarcoma had an amputation. And then as they started some of the neoadjuvant chemotherapy regimens, they were able to establish that limb salvage was indeed safe, right? So they looked at patients who had limb salvage surgery above knee amputations versus a hip disarticulation, and their survival rates were relatively similar. You will see that it's not statistically significant, but obviously the survival time is slightly different, and your risk of local recurrence can be higher in patients that you perform limb salvage surgery on, but also not statistically different. And the chance that you have a local recurrence if you're trying to salvage a limb that really shouldn't be salvaged is obviously going to be higher, right? So there's a lot of work that goes into trying to figure out whether or not you should be saving a limb. And sometimes you just can't. I'd say there's like 10% of our cases where limb salvage is just not going to be an option. So before patients got chemotherapy, the survival rates for osteosarcoma were abysmal, right? So in the 70s, 20% of the kids, and these were kids that were all getting amputations, 20% of them survived 5 years. With chemotherapy, those survival rates are now in the 70s for 5-year survival rates. So you have to really remember that it isn't your surgery that's saving the child, right? It's the chemotherapy. And so your surgery needs to be planned so that the kids can get back to chemo, right? And so we currently give patients chemo up front. We plan for the surgery, we resect them in about 12 weeks, and then we do chemo on the back end. But you're not the one that's saving them. It's the chemotherapy. So anything that you can do to get them back to chemo is going to be beneficial. And delays from surgery time getting back on chemo can affect their survival. So if you have a big complicated procedure that needs a free flap and then the free flap dies and then the patient has to go back and now suddenly it's a month or two before they get back to chemo, that can affect their prognosis. So that needs to sort of weigh into your decision whether or not you're going to be doing limb salvage as well. Their prognosis also greatly depends on their response to chemotherapy. So we currently resect the sarcoma after their chemotherapy is given, and then the pathologist will cut it up into tiny little blocks and grade the response to chemotherapy. So if they have no viable tumor, their 5-year survival rate is 91%. I'm sorry, their 5-year event-free survival rate is 91%. If they have a poor response to chemotherapy, that goes down to 49%. So the pathologist looks at this. The slide on the top is active tumor, and the slide on the bottom you see that it's all necrotic, that there are no active cells there. So this really helps us prognosticate how they're going to do afterwards. They tried to do some studies looking at whether they should change the chemo regimen in the sort of middle if they've seen that the response is not good, and there hasn't been any any new literature that's come out on whether or not they've come up with any way to actually do that. So currently they continue with the same regimen. You want to also look too at your radiographic response, not just your response to chemotherapy, but this is one of the things that can help you also resect your tumor, because the tumor sometimes will ossify in response to the chemotherapy. So now it feels firm when you're resecting it and not mushy. And then you can kind of surgically feel a little bit better where the tumor starts and stops. So that's one of the benefits of giving the chemotherapy up front as well. So if you'd had a, you know, you may be less likely, although it's not been shown in studies, you might be less likely to get a positive margin because you can feel where things start and stop. And if you did get a positive margin, your tumor might be dead, right? So that can be helpful. So when we come to surgical reconstruction of these types of tumors, we have a lot of different options. Dr. Patterson was one of my fellowship directors, and he always likes to keep things simple. She's like, you got the 5 A's, you got amputation, you've got arthroplasty, you've got allografts, you've got autografts, you've got allograft prosthetic composites, right? So you kind of keep that together with what your treatment options are. So we'll talk a little bit about what that looks like. But essentially, you have biologic and you have not biologic, and there's, you know, pluses and minuses of all those. So the allograft is gifted bone that we sometimes use for reconstruction. And I would say that the best place for that is pretty much an intercalary area. The failures that occur really in the first few years, and then it becomes stable down the person's life. Whereas with arthroplasty, they don't have the failures early on, mechanical failures, but then the joint replacements wear out further on. So there's definitely, you know, pluses and minuses of both and trade-offs. And depending on the location is going to help you decide what kind of reconstruction you're going to use. The complications of allograft obviously include fracture, non-union, infection. You can use them in an osteoarticular fashion. You can use them in an intercalary fashion. You can use them with a prosthesis. You can fuse with them. So there are a lot of different options. The planning for this has to be pretty robust, because once you resect the tumor, you need to have an allograft to put in there. So you've got one that's in the freezer, so you can't drop it on the floor, right? You got to know that they sent the right side, you know. So these are the kind of things that we lay awake at night thinking about. You know, you check the freezer, you check it again, you take an x-ray of the thing in the freezer, and then ultimately you make sure that when you take it out of the freezer that you're opening it and you're putting it right on the table and nobody else touches it. So you know, you could always, I guess, put some a cement block in there if something happened to your allograft, but it's pretty poor form. So you want to make sure that that you've planned appropriately, sized correctly, and communicated well with your bone bank. So the different types of allograft, osteoarticular allografts can be used if you're trying to preserve a joint. We don't typically do that a lot because osteoarthritis becomes a problem. The cartilage doesn't actually, even though they do cryopreservation, it doesn't actually hold up very well. But if you can retain some of the bone stock, then you can do a joint replacement into your allograft if it's already incorporated. So this is a picture of somebody who had a proximal tibial osteosarcoma. You can see there's quite a bit of soft tissue mass. You can tell you're proximal, right, because you've got your patella tendon here. And this is our surgical reconstruction, where we were able to keep the ACL, PCL, and just resect this. And this is, you know, also challenging to figure out where you're going to start and stop. But the navigation tools are a little bit helpful if we're trying to plan really close margins. So we use that a little bit, especially in the pelvis. So this is what that looked like ultimately. So you can see that it's just really this medial joint surface. And you have to remember that you've got the meniscus there. So if you can preserve the meniscus and tack that down and it lives and you've got enough stability and your collaterals, this can be a pretty good function. Fortunately, this patient had 100% tumor necrosis, which then makes you feel a little bit less nervous about having close margins. In the intercalary setting, they have a lower complication rate compared to osteoarticular allografts. And in an intercalary setting, we have intercalary endoprosthesis, but they are typically utilized in patients with metastatic disease with a short lifespan. There's a lot of challenges with putting an intercalated prosthesis in, aseptic loosening, rotation of the implant. We just haven't quite got a great endoprosthetic reconstructive option for young patients. So an allograft can be an attractive option there. You can also use them to do alloarthrodesis. I have never done one of these cases. This is an alloarthrodesis. This is from my partner, Dr. Benevenia. But before we had custom implants that we could sort of pull off the shelf and do a distal femoral replacement, this is what people were doing to reconstruct limbs. Also, if you needed to do a extra articular resection because there was tumor in the joint, this would be something that you'd be considering. But the patients don't do great. They have a stiff knee, for a fused knee for life. It doesn't make, so think about where you're sitting right here in your chair. Everybody's got their knees bent. So you can't sit in these chairs. You got to sit on the aisle with your legs sticking out. So people do not like having a fused knee. You have a risk of fracture, risk of non-union, definitely not a panacea. But where I do think the alloarthrodesis works well is if you have a distal radius tumor. And a lot of times we're doing that for giant cell tumor that's recurred, multiply recurred, and you really don't have anything left. You can resect the whole distal radius and put an allograft in there and then fuse across the wrist joint. So that's one of the areas where alloarthrodesis can be helpful. You can combine your allograft with the prosthesis. So the advantage of that is if you order an allograft that has soft tissue attachments, you can reattach your soft tissues to where you've done your resection. So in this case, right, you've got to take your whole rotator cuff off, pretty much close to the glenoid. And then the allograft comes with all these soft tissue attachments and you can reattach that. And sometimes you get better function. I will tell you in the proximal humerus, before really doing the reverse, patients, any type of proximal humeral resection, they don't have great function. They can kind of do a little winging of it, but they don't really have overhead function. But sometimes with allograft prosthetic composites, you get lucky and the patients have pretty good function because you've been able to restore their soft tissue attachments. But then you have the complications really of an arthroplasty and an allograft. So but you only have one junction that you have to get to heal. So sometimes it's an attractive option. Well, like I talked about before, endoprosthetic reconstruction offers immediate post-op stability, right? We cement them in, most of the time we cement them in. Not everybody in the tumor world cements them in, but over time they don't last, right? You get bearings that wear, you get stems that break, you get aseptic loosening, you get septic loosening. So realistically, you have to tell your patients, all right, looking at this timeline, would you rather, if you have a tumor that's in the middle of the femur, would you rather have a proximal femoral replacement or distal femoral replacement? Well, you should do proximal if you're kind of in the middle because they're going to have a greater longevity. These things, if your patients live 15 years, you're going to need to probably revise about 30% of them. But I tell my patients, like, I'm happy to revise you. If you live and get through this, we're going to be happy to revise you when you get down the road. So let's not worry too much about that. So for immediate stability, and for most of our patients, we do use endoprosthetic reconstructions. And this is a patient who had an osteosarcoma of the distal femur, and you can see they've also got a skip lesion up in the intratrochanteric area. This is your pathology. Again, the lace-like osteoid, a lot of malignant cells surrounding the osteoid. So the treatment options for them, right? Hip disarticulation to get rid of that lesion, a distal femoral replacement, and a proximal femoral replacement. We opted to do a total femoral replacement. So, how long is this going to last? That's a very good question. What's the patient's function going to be? Well, total femoral replacements have an average knee range of motion of 40 to 50 degrees. So not superb, but if you're looking to save a limb, and probably, better than a hip disarticulation where you can't have a prosthesis. But again, like I said, they do fail. And so this is what a reconstruction looks like 15 years after an osteosarcoma. This is an odd type of distal femoral replacement where it was sort of like a ball and socket. But you can see that there's loosening of the proximal femur. And this is also one of the things you want to think about when you're doing your surgical resection and reconstruction, is preserving some of that bone stock for down the road. So if you, took that all out and did a total femoral replacement, you'd have you'd have better margins, right? But then you'd have less bone to work with. So in this patient, we were able to do a custom prosthesis where the stem has a hole in it, and then you can cement and do this cross pin fixation to help when you have limited bone stock. We also have the issue of the growing child, right? So some of our sarcoma patients come to us and they are, 10, 11, 12. I've had a 5-year-old who had osteosarcoma. So they still have growing, they're still growing. So get a bone age, right? And if you don't really know how to deal with that, call one of your pediatric orthopedists. They help navigate, like, how much growth do we really have remaining, right? We all learn that in residency, and then somehow you think you're never gonna have to use it again. And then you're like, how much growth have we got? Is it 9 and 6? You have to think about what your treatment options are in the growing child. So sometimes, they're 12 and they probably got another centimeter or 2 that they're gonna grow. And so in that case, you're probably maybe trying to make them a little bit long with surgery, and then giving them a shoe lift on the other side. The other option is to not worry too much about that and then have your pediatric orthopedist do an epiphysiodesis on the contralateral side once they get off chemo and they start to regrow again. So there's a lot of different options. If you're talking about a large limb length discrepancy, and mostly we're talking about the distal femur, proximal tibia, then you've got to think about whether an amputation would be more functional, or a rotation plasty would be more functional, or can you use a growing prosthesis? So there are 2 basic growing prostheses. One is the rapiphysis, which I have the most experience with, and the other is the Stanmore, which I haven't used. I will tell you, they are not great prostheses, right? It sounds great. We're going to grow it. It's going to be non-invasive lengthening, but they're really not super robust. So the rapiphysis works. Let me just show you this next slide. The rapiphysis is essentially, if you think about it like a toilet paper tube, right? You have like 2 tubes inside each other, and then there's a spring inside. They are they're kind of locked together by this little flare on the inner tube that locks into the outer tube. And then when you put an electromagnetic field around it, heat is generated and allows it to expand a little bit to sort of unlock these trumpet flares. And then that spring, which is compressed and has stored energy, can then expand your prosthesis. So that sounds really exciting, but sometimes it doesn't work, right? So you're putting this limb on, you've got the patient asleep, you put the ring on, you're ready to expand, and it doesn't move, right? And then the limb heats up, you're generating all this heat, and I've had to actually change, we've had to actually change to another rapiphysis because the child wasn't done growing because the first one wasn't expanding. It's also not very scientific. So if you look at the manual, it'll say hold the button for 20 seconds to generate the field, and that will expand, 5 seconds expands a 0.5 centimeter and 10 seconds expands it. It doesn't work like that. You're holding the button, you're flooring the whole time, you're watching to see if it moves, and you've got to be pretty precise with, looking at your fluoro, measuring it out, putting some landmarks on the screen so that you actually can see it moving, because it moves pretty slowly, but sometimes you can actually see it moving. And sometimes you hit the button and, you hold the button for 2 seconds and it expands, right? And sometimes you hold the button for 20 seconds, it barely moves. So, and then the other thing is that the thing that holds it together, this is going to sound crazy, is this little pin right here, right? So you have a stem that has a little hole in it, and then you put that on, it's not even a Morse taper, but it does intussuscept, and then you put this little tiny pin to hold the thing together. So it always feels a little bit like, let's just try to get the kid to equal limb lengths, and then you change it to an adult prosthesis. So you have to tell the patients that this is not a one and done operation. This is, we're going to try to get you to equal limb lengths and then convert you to an adult prosthesis. And most of the time in our patients, we've been able to have them get to skeletal maturity, have their limbs be equal, and then we wait for the prosthesis to fail and then change it to adult prosthesis. So the way it typically fails is that something happens so that those two cylinders are no longer locked, and then the patients it's like a pogo stick, right? So they're kind of moving up and down, and it creates a lot of wear debris. So patients will come in saying they feel unstable, and then you examine and you're like, it feels kind of pogo sticky, and then you get an x-ray and you'll see that there's a lot of wear debris. So so that's one of the options for a growing child. But I would say that if you can avoid doing that, and, you know, deal with a shoe lift or do an epiphysodesis. If you've got like 2 to 3 centimeters that you're talking about, those are a little bit more reasonable options. These are for, you know, if your child is 5 to maybe 10, that's something that they're thinking about. And then also, you know, we have to think about amputation as a real option, right? So generally they have lower functional outcome scores, but not necessarily always, right? If you're really trying to preserve some limb that needs a free flap, that you've had to take the sciatic nerve, that need a vessel bypass, you know, all those things really increase your level of complexity, decrease the chance that you're going to be able to go back to get chemotherapy. You want to really think about an amputation. An amputation generally has a much lower risk of reoperation. So a lot of these patients that are getting surgery for skeletal sarcoma, they got to go back for something immediately, you know, in the middle of chemo, after chemo, 15 years down the road. Amputation is generally less risk of reoperation. And some of the times you want to think about it are if you have pathologic fracture, although it's not necessarily an absolute indication, nerve vessel involvement, all those things you can deal with like 1 or 2 of those things, but you can't necessarily deal with all of them at the same time. And I've had to do amputations for people who just really had nothing but tumor. So there was no soft tissue envelope, right? Distal femur, you've seen it, right? It expands all the way out and all you have really is skin left around it. It's just not possible to salvage some patients' limbs. People always ask me a little bit about approaches, so I just want to throw that in there so that we can talk a few minutes about that. But it typically depends on the location and where the neurovascular structures are. So this is just from a book that you used to be able to get on sarcoma.org, but I'm not sure if you can still do that. For the upper extremity, you know, we're planning out our surgical incision. We're putting our biopsy right through the anterior fibers of the deltoid. For pelvis, we use what we call a utilitarian approach. We don't always use the limb that goes along the pubis, but you're essentially coming along the iliac crest and down around and bringing the entire glute back. So you want to make sure that your biopsy line is in track. Your biopsy track is in line with that planned incision. For distal femur, proximal tibia, for the distal femur, you can go medial or lateral. I find that it's a little easier to go medially because your vessels are kind of right there. Whereas if you're lateral and you're doing your biopsy, you've got the biceps femoris posteriorly that you're trying to get around to get to the vessels. So, but sometimes your soft tissue mass is laterally, and that's the way you need to do your biopsy. And so then you have to deal with that for surgical resection. And the same thing for tibia, this is the wrong picture, but you want to do a biopsy sort of right along the medial crest, right where there's not as many soft tissue attachments. So that's really, you know, sums up looking, you know, staging, biopsy, resection, reconstruction. I did want to just mention some of the more typical sarcomas that we deal with because I think they come up on the in-training exams. And that's helpful to sort of know what you're looking at radiographically and what you're looking at histologically. So your primary bone sarcomas are osteosarcoma and Ewing sarcoma. So an osteosarcoma typically occurs in, you know, younger adolescents. If you have an osteosarcoma in an older patient, it's typically associated with Paget's disease or radiation, right? So there's secondary osteosarcomas. These lesions typically arise in the metaphysis, they erode through the cortex, and they create a soft tissue mass. What you're going to see histologically is you're going to see, again, that lace-like osteoid, lots of malignant cells, but the osteoid is the key, right? The pink osteoid with a lot of cells around it, you're thinking osteosarcoma, especially if you had an x-ray that looks like that, right? This is probably a post-chemo treatment x-ray, which is why there's so much bone activity there. Typically, you'll see that as you get your patients through chemo, that if you take x-rays as you go along, the soft tissue mass starts to ossify. And again, that can be helpful with surgical reconstruction or resection, and really can tell you the extent of the soft tissue mass as well, which you sometimes can't appreciate pre-chemo. Your treatment for osteosarcoma is a CT of the chest, bone scan, MRI, and you get neoadjuvant chemotherapy, and then you get resection, reconstruction, and post-op chemotherapy. The reason that we do the neoadjuvant chemotherapy is when we first started treating patients with chemotherapy, the implants were not modular like they are today. So you would have a patient diagnosed and you'd say, okay, you go off and get some chemo while I figure out what kind of implant I'm going to order from the company. So you would order the implant, they would custom make it. And then by the time you had that done, it was like 12 weeks down the road. And so then you did your surgery and then you sent them back to chemo. That then started allowing them to do the grading for tumor necrosis and kind of set up the stage for what the protocols look like. So the protocols still look the same, even though we have the prosthesis on the shelf now. So they're all generally all modular. So you can kind of, okay, we're going to reconstruct a 12 centimeter defect. We need, you know, a 9, and right. So we're going to add these all up and we've got everything that we kind of need. For younger kids, we sometimes don't have what we need. They might have a small canal, so you need a custom stem. And I think also, you know, there's a lot of trauma that goes into getting treated for an osteosarcoma and having that diagnosis. So I do find that it's pretty helpful to say, okay, we've got this diagnosis, we're going to get some chemotherapy. And then you have a little bit of time to really talk about this life-altering surgery that's going to also happen to the child. And you have also a little bit of time to plan, to get a new MRI, to order an allograft if you need. So we continue with those protocols, even though there's no survival benefit of having neoadjuvant chemotherapy. Chondrosarcomas are a totally different age group, and something that you need to think about, because this is what gets us into trouble, right? The kid, we're like, okay, that's aggressive, bad, you know, sarcoma. We forget that adults can have sarcomas too. So they're generally over the age of 40. We see them in the pelvis, proximal femur, proximal humerus. And this is what you're seeing on the x-ray. You're seeing bone destruction. You see the stippled cartilage more distally. Your MRI will show a soft tissue mass. Your x-ray may show just some endosteal scalloping. The patient will have pain. What you see histologically is cartilage, right? So we can recognize that blue is cartilage. But the chondrocytes are really large. They sometimes are binucleate. There's too many of them. You know, normal cartilage is not this hypercellular. Treatment for that: chest, CT chest, whole body bone scan, MRI, radical resection. You do not do chemotherapy, right? For chondrosarcomas. So you curettage them. If you can curettage them if they're low grade. So we could have a whole discussion about cartilage tumors and in chondromas versus low-grade chondrosarcomas versus high-grade chondrosarcomas. But if they're low-grade, there is a case for curettage. Correct. Yeah, exactly. Thank you. Ewing sarcoma, again, younger age group. Sometimes it's more likely to be in the diaphysis location, but you can have it in the metaphyseal location as well. You're going to get the same type of reaction periostally that you do with osteosarcomas. Although I feel like with Ewing's, it's a little bit more central and expands outwards. So you see a little bit, oftentimes see a little bit more of the onion skinning rather than just the Codman triangle. Small round blue cell tumors. So our small round blue cell tumors are Ewing sarcomas, some lung cancers, and lymphoma. So really important that you take these tissues fresh to pathology, because you need to do cytogenetics and sometimes flow cytometry. If you're thinking it could be a lymphoma, then you just say send a piece for flow. So any small round blue cell tumor, cytogenetics, flow, it's just best if you take the tissue down fresh to pathology. Sometimes you know more than they do, and you just tell them you're going to send it for flow, you're going to send it for cytogenetics, and then we'll process the rest. So 1122 translocation that we see, that's commonly tested. I think everybody knows that, but it produces a fusion protein that we see in Ewing sarcoma. The treatment for that, again, CT chest, whole body bone scan, MRI. There's two treatment options for Ewing's. You can do chemotherapy and radiation, or you can do chemotherapy and surgical resection. I would say that the majority of patients get surgically resected. Radiating at sarcoma doses in a young child, it's going to kill the physis, and then you have the side effects of whatever radiation that you had done. That being said, there are some locations where it's just not surgically resectable, and so you would do radiation. Some people have done that in the pelvis, sometimes in the spine, but typically we like to resect if we can. Again, wide resection, not necessarily radical, but yes. Periosteal osteosarcoma is a type of osteosarcoma that is low grade. It's a surface lesion. They don't get chemotherapy. Most common location is the posterior distal femur. And again, it has a lower grade appearance on the pathologist would have to tell you that. I couldn't tell you that's low grade or high grade, but it has this stuck on appearance. It's usually back of the femur. And the treatment for that is just, same staging, but just surgery. And then there's the periosteal osteosarcoma, a little bit higher age group, but you can see that it's a surface lesion. The bone actually looks pretty normal, and it's an intermediate grade. And so that's a lot of, not hemming and hawing, but a lot of discussion with the medical oncologists about whether or not they get chemo when it's an intermediate grade, but generally they're getting chemotherapy, surgery, and reconstruction. So in summary, we want to make sure that we stage our patients before we do the biopsy. We'd like to follow all the principles of biopsy. We're using wide margins for surgical resection, and you have a lot of reconstructive options. Any questions? Yeah, sure. Sure. Correct. Mm-hmm. Mm-hmm. Yeah. Right. Mm-hmm. Yeah. Yeah. Mm-hmm. Mm-hmm. Yeah. 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 Right. Yeah. Yeah. I think that helps. It helps if you have a reliable musculoskeletal radiologist as well. And I think that, oh, there you go. Sorry. Sorry. Okay. I won't say, I think that can be super helpful. Also, as you know, like there's plenty of times where I've logged in the system and put my 2 cents in as well, right? So that can be helpful to have somebody who also looks at these things on a routine basis. I personally almost always do a frozen section, even if I'm probably dealing with NOF. Just because I think that the downside of making a mistake is just too great. And that also being said, I think you have to sort of prep the pathologist a little bit too. So I've definitely been in situations where I'm like, I went over it with the radiologist. He thinks it's an NOF. I think it's an NOF. I'm looking at the slides with you. Are you seeing any malignant cells? So you may not get a diagnosis, but you can sometimes get the pathologist to say, is there any evidence of malignancy here? And if the answer is no, then okay, you can kind of move along. It also becomes challenging when you're dealing with like giant cell tumor or like ABC versus UBC. Those are treated differently, right? So sometimes they can't tell you that. And then you're stuck sort of trying to be a little bit more aggressive with the UBC that they think might be an ABC, even though you think it's a UBC. So, pathology is super important. I mean, and there are places that I just won't do a case because I don't think I'm going to have reliable enough pathology there. And then also knowing what your resources are in the system. So if there's any way you can get a pathologist that is trained to be able to be available for the frozen, that's helpful. I think we're going to ultimately get to where we kind of a little bit are with radiology, which is the radiologist doesn't actually need to be here to read that, right? And, pathology, come on, this is like the digital age. You can scan slides in, they could connect the microscope to a computer. There's all sorts of ways that a pathologist who's trained in musculoskeletal oncology would be able to read the slides, but currently they're limited by not having privileges, right? So I think that we'll eventually get to that point, but we're not there yet. Yeah. Yeah. Right. Yeah. Yeah. Right. 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 Yeah. Well, and that's why your staging studies too are important, because you go down there. It is even with the trained musculoskeletal pathologist, it is a negotiation. Like I go down there with this is what I'm saying. They've got a lung mass, they've got adrenal nodules, they're 80 years old. It looks like it's probably going to be metastatic lung cancer. And so then when you look at the frozen, you're like, I see a gland, that's got to be, you know, carcinoma. So, and then you have to say, what are you going to put on your paper? Are you going to put, you know, lesional tissue identified? That's not going to help me. But if you can put no tumor seen, you know, I think that's helpful. And sometimes they're going to be like, I have no idea what this is, and this looks a little scary to me. And then you have to stop and you have to wait. You have to say, okay, we're going to put you back in a splint. We always prep our patients for that too. Not fun and not help, people are not happy, but sometimes that has to happen. Deidre?
Yeah.
It seems like it's pretty much the same. I mean, I think, you know, we all think metal's going to solve everything, but you know, there are a lot of cases where it just doesn't. Even if you've got, you know, shorter stems that you need, like the compress, I didn't talk about that, but you only need 7 centimeters of bone to be able to put a stem in and reconstruct. So some of the things are a little bit helpful, but I don't really think they're really moving the needle much. Dr. Gatt?
So in regarding enchondromas, so
Yeah.
so as a medicine doc, I'll see pretty frequently a distal
Right.
femur or
Right.
a proximal tibia lesion. Patients having vague pain, I attribute it to patellofemoral pain,
Right.
like I attribute everything to.
Yeah.
And but at what point am I afraid of that enchondroma? Like, what should I be looking for?
Yeah,
Because I
so-
see that too
all the
often.
Yeah, I mean, that's a great question. I in my time doing this since I started residency, so we're like 22 years, I've seen 2 enchondromas convert to chondrosarcomas, right? One of them, she had an enchondroma on a chest x-ray, so we know that it was there. And then, you know, 15 years later, she has a chondrosarcoma. So it can happen. And in another patient, I've seen it as well, but they've both been proximal humerus. But we see tons of enchondromas. So it's not happening a lot, right? But it can happen. So I think that, first of all, you want to make sure that your radiographs look like an enchondroma, right? So you just little stipple calcification. If you get an MRI, it's just sitting there, it's minding its own business. There's no edema surrounding it. There's no soft tissue mass. You can get a little bit of push on the cortex, but there really shouldn't be endosteal scalloping. So soft tissue mass, edema, erosion of the cortex, that's all, you know, you got to go somewhere else. If it looks like a benign enchondroma and they have other reasons for their pain, so rotator cuff pathology, if they get better with an injection, you know, those are all helpful signs. When the patients come to me because somebody doesn't want to watch them, then, you know, if they're having some pain, I'll say, get your treatment that, you know, it looks like an enchondroma, get your treatment that you're getting with your sports medicine doctor, because I don't want to do injections and be part of patellofemoral pain. So I'm happy to have somebody else do that, but go ahead and get your treatment and I'll follow this, right? So I get an x-ray, and this is definitely overkill, but it's 6 weeks, 3 months, 6 months, and then a year. And then I have them come back once a year, we shoot an x-ray, or sometimes now we can do telemedicine visits. They can get x-ray, we talk on the screen, not a big deal. People usually come 3 or 4 years and then they get tired of seeing me. They're like, do I really need to come back every year? Probably not. But if you know, if you had a reliable patient, you could say, if you have a new pain or a different pain, we need to get an x-ray. You have this thing, it needs to be monitored. Are you going to pick at some change up on an x-ray once a year? Never happened for me. So probably not useful, but I'm the tumor doctor, so I can't be wrong. So that's what I do. So I think you could probably, you know, offer them surveillance, check on it every once in a while, send it out if you don't want to, ask them to come back if they have pain. I think there's lots of different options, but most orthopedic oncologists are following them at least yearly. Yeah. Thank you.